Good evening and welcome to tonight's webinar on Autism Spectrum Disorder. My name is Clara Joe and I am JCU Dentistry CPD Coordinator for this year. Before we begin, we'd like to acknowledge the Australian Aboriginal and Torres Strait Islander peoples as the first inhabitants of this country and pay our respects to traditional owners and elders, past, present and emerging of the land on which we each stand today. It is my great pleasure to introduce you to Associate Professor Andrew Lee, who will be speaking on Autism Spectrum Disorder. Prof. Lee currently holds appointments as Associate Professor of Preventative and Special Needs Dentistry and Deputy Head of the School of Dentistry at James Cook University. He is also the immediate past President of the Australian and New Zealand Academy of Special Needs Dentistry. Just a few housekeeping items before we get started. There are a few CPD certificate eligibility requirements that you can see on the screen. A link to the CPD survey will be provided at the end of the Zoom session, and in the survey there will be a number of content questions as well that will enable you to test your knowledge after this session. If you have any questions during the webinar, please submit them using the question and answer box that you'll see below. So you'll see on this slide here that there is a section where you can submit your questions. Questions will be answered in the final 10 minutes of this 60-minute webinar session. And now I'll hand over to Prof. Lee. So thank you very much, Prof. Lee.
Thanks very much, Clara. So I would like to again acknowledge and pay my respects to the traditional custodians of this land on which we all stand, the past, present and emerging. So today's CPD lecture is going to be on autism spectrum disorder. It's not a processing area, it's a different operating system. So autism spectrum disorder is classified as a complex neurodevelopmental disorder affecting three main domains, which include impaired social interaction, impaired communication skills, as well as sensorimotor deficits combined with stereotyped and restrictive behaviours. The oral health care of clients with autism spectrum disorder may present a number of challenges, not least two different operating systems trying their best to interface with, on occasion, frustrating outcomes. This lecture aims to provide a broader understanding of individuals living with autism spectrum disorder and their clinical dental management. So are you all sitting comfortably? Then I shall begin. I find people confusing. This is for two main reasons. The first main reason is that people do a lot of talking without using any words. Siobhan says that if you raise one eyebrow, it can mean lots of different things. It can mean, I want to do sex with you. And it can also mean, I think what you just said was very stupid. Siobhan also says that if you close your mouth and breathe out loudly through your nose, it can mean that you are relaxed, or that you're bored, or that you're angry. And it all depends on how much air comes out through your nose and how fast, and what shape your mouth is when you do it, and how you're sitting, and what you just said before, and hundreds of other things that are all too complicated to work out in a few seconds. The second main reason is that people often talk using metaphors. These are examples of metaphors. I laughed my socks off. He was the apple of her eye. They had a skeleton in the cupboard. We had a real pig of a day. The dog was stone dead. The word metaphor means carrying something from one place to another, and it comes from the Greek words meta, which means from one place to another, and phero, which means to carry. And it's when you describe something by using a word for something that it isn't. This means that the word metaphor is a metaphor. I think it should be called a lie, because a pig is not like a day, and people do not have skeletons in their cupboards. And when I try to make a picture of a phrase in my head, it just confuses me, because imagining an apple in someone's eye doesn't have anything to do with liking someone a lot, or it makes you forget what the person was talking about. My name is a metaphor. It means carrying Christ. It comes from the Greek words Christos, which means Jesus Christ, and Pharaoh. And it was the name given to St. Christopher because he carried Jesus Christ across the river. This makes you wonder what he was called before he carried Christ across the river. But he wasn't called anything because this is an apocryphal story, which means it's a lie too. Mother used to say that it meant that Christopher was a nice name because it was a story about being kind and helpful. But I do not want my name to mean a story about being kind and helpful. I want my name to mean me. These are some reasons why I hate yellow and brown. Yellow. Number 1, custard. Number 2, bananas. Bananas also turn brown. Number 3, double yellow lines. Number 4, yellow fever, which is a disease from tropical America and West Africa, which causes a high fever, acute nephritis, jaundice, hemorrhages, and it's caused by a virus transmitted by the bite of the mosquito Aedes aegypti, which used to be called Stegomyia fasciata, and nephritis is inflammation of the kidneys. Number 5, yellow flowers, because I get hay fever from flower pollen, which is one of 3 sorts of hay fever. The others are from grass pollen and fungus pollen, and it makes me feel ill. Number 6, sweet corn, because it comes out in your poo and you don't digest it, so you're not really meant to eat it like grass and leaves. Brown. Number 1, dirt. Number 2, gravy. Number 3, poo. Number 4, wood, because people used to make machines and vehicles out of wood, but they don't anymore because wood breaks and goes rotten and has worms in it sometimes. And now people make machines and vehicles out of metal and plastic, which is much better and more modern. Number 5, Melissa Brown, who is a girl at school who's not actually brown like Anil Mohammed. It's just her name, but she tore my big astronaut painting into 2 pieces and I threw it away, even though Mrs. Peters sellotaped it together again because it looked broken. Mrs. Forbes says that hating yellow and brown is just being silly. And Siobhan said that she shouldn't say things like that and everyone has favorite colors. And Siobhan was right. But Mrs. Forbes was a bit right too, because it is sort of being silly. But in life, you have to make a lot of decisions. And if you don't take decisions, you would never do anything because you would spend all your time choosing between things you could do. So it's good to have reasons why you hate some things and you like others. It's like being in a restaurant, like when Father takes me out to a Burnie Inn sometimes, and you look at the menu and you have to choose what you're going to have. But you don't know if you're going to like something because you haven't tasted it yet. So you have your favorite foods and you choose these, and you have your foods that you don't like and you don't choose these, and then it's simple. So this is a little bit of history to start with about autism. So first described by Leo Kanner in the USA and Hans Asperger in Austria in the late 1930s and early 1940s. Hans described the milder form, later known as Asperger's syndrome. It's quite interesting that these founding fathers of the diagnosis of autism are 2 diametrically opposed figures historically. Hans Asperger first designated a group of children with distinct psychological characteristics as autistic psychopaths in 1939, several years before Leo Kanner famously wrote his paper on autism in 1943. Hans Asperger is a controversial figure, initially perceived as the savior of children with autism by saving them from the concentration camps with his special diagnosis. He in fact managed to accommodate himself into the Nazi regime and was rewarded for his affirmations of loyalty with career opportunities. He joined several organizations affiliated with the National Socialist German Workers' Party, although not the Nazi Party itself. He publicly legitimized race hygiene policies, including forced sterilizations, and on several occasions actively cooperated with the child euthanasia program. The language he employed to diagnose his patients was often remarkably harsh, even in comparison to the assessments written by staff at Vienna's notorious Spiegelbund Euthanasia Institution, which belie the notion that he tried to protect these children under his care by embellishing their diagnosis. Leo Kanner, on the other hand, was born in Austria and educated in Berlin. He came to the US in 1924, and in 1930 he moved to the Johns Hopkins University, where he founded the first child psychiatry clinic in the country. Based largely on his clinical experience, he then wrote a textbook that defined the field of child psychology. His humanism is evident in his lifelong fight against the abuse of children with autism and intellectual disability and his enduring concern for their families. He also made extraordinary efforts to help physicians and scientists escape from Nazi-controlled territories. So the Centre for Disease Control has the definition of autism spectrum disorder as a group of developmental disabilities that can cause significant social, communication and behavioural challenges. A lifelong developmental disability with onset before the age of 3 and characterised by impairments in verbal and non-verbal communication skills, impairments in reciprocal social interactions, as well as stereotyped behaviours, interests and activities. There's lots of debate and published figures around the prevalence of autism. So the most recent I've come across in Australia is the Australian Bureau of Statistics, and they published those statistics on autism in 2018. There are approximately 200,000 Australians with autism, which is a 25% increase from 2015. Males were found to be 3.5 times more likely than females to have this condition. And importantly, though, children with disabilities are almost twice as likely to have unmet oral healthcare needs than their peers or neurotypical peers without disability. So this is the autism triad, which, so autism spectrum disorder is diagnosed based on the presence of multiple symptoms that disrupt a person's ability to communicate, form relationships, explore, play and learn. So previously the DSM-IV refers to the basic triad, which you can see there, of problems underlying autism as impaired social interaction, impaired social communication and restrictive behaviour patterns. The DSM-V reduces these to two categories. So impaired social interaction and communication are now regarded as one conjoined problem and restrictive behaviour as a second. However, as a health professional or a parent, it is easier to look at problems with social skills separately from those problems of speech and language in order to understand the symptoms. So this is an article written before the transition from the DSM-IV to the DSM-V. A lot of the criticisms around the DSM-V new criteria, which is popular amongst those with limited understanding of autism, is that widening the criteria of autism spectrum disorder has led to a marked increase in published prevalence. In actual fact, the widening is from the increased knowledge about autism spectrum disorder, and the DSM has followed this and not started this clinical trend. So following on from the triad previously described, the DSM-V has grouped together social interaction and communication into one problem and restrictive into domain, as I've just said. The criteria following that in order to have positive diagnosis of ASD, the individual must have the following. So persistence in disorder of social communication and social interaction across multiple contexts, including social and emotional reciprocity, non-verbal communication behaviours, developing and maintaining and understanding relationships. In addition to that, the individual must have restrictive, repetitive patterns of behaviours, interests or activities as manifested by two of the following, including stereotyped or repetitive movements, use of objects or speech, insistence on sameness, inflexible in adherence to routines or ritualized patterns or patterns of verbal or non-verbal behavior, highly restrictive fixed interests that are abnormal in interest or focus, as well as hyper or hypo reactivity to sensory input or unusual interests in the sensory aspects of the environment. In addition to that, the symptoms seem to be present from an early age, and importantly as well, so as not to broaden the prevalence, The individual must have symptoms that cause clinically significant impairment in social, occupational or other important areas. So this is not to include everybody with traits that I'm sure we can all identify and think of into an individual as having autism spectrum disorder. And of course, these is all under the context that these disturbances are not better explained by an intellectual disability. Other additional specifications include whether or not the individual has an intellectual disability, whether they have any language impairment, whether or not it's associated with another neurodevelopmental or mental behavior, mental or behavioral disorder, if it's associated with catatonia, or whether or not it's associated with a known genetic condition or environmental factor. Following this diagnosis, the individual is given a severity from a level 1 to a level 3, with level 3 requiring very substantial support. So these are the previous terminologies around autism. And I think it is important to remember the old terminology as well as the newer classifications, because often, people, particularly older adults that have been around, may identify with these, with this terminology. So previously we've had autistic disorder or Cana's disorder, and these patients were identified as having more social activity, higher empathy, and greater interaction. I'm just getting a lecture. Pervasive developmental disorder not otherwise specified. So these patients, sorry about that, everybody, patients with moderate social activity, empathy, and interaction. Childhood disintegrative disorder, late onset of developmental delays in language, social function, and motor skills, more severe sensory processing disorder, but less severe cognitive problems. And then we've got classic Asperger's syndrome. So those are individuals with relatively high functioning, normal language, normal skills, normal intelligence, however, having poor social skills and decreased ability to show empathy. So I'm sure we can all identify or picture different stereotyped behaviour associated with autism spectrum disorder. So these are repetitive or ritualistic movements, posture, or utterances. Individuals with autism follow rigid routines, and they're very attuned to the rituals and lists. The characteristic movements include rocking or banging head, flicking fingers near eyes, hand flapping, facial grimacing, jumping, and toe walking. So impairment of social interaction. This can be variable. Individuals can have variable ability to form emotional relationships. They can have difficulty interpreting languages and nuance of languages, as illustrated by the passage that I have read. They may not initiate or respond to smiling. They may not like physical, affectionate physical contact, including touch, cuddles, kissing, greeting, and hand waving, particularly if the physical contact is light touch. Eye contact may not be possible, and a person with ASD may lack empathy. This is really important. A person with ASD may lack empathy, but they may have sympathy in situations where they can perceive somebody else's distress. So this is something that Hans Asperger didn't get, because he didn't understand the difference and the idea of impaired theory of mind, which is why he called individuals with autism autistic psychopaths. So impairment of social communication. So individuals have a decreased ability to converse both verbally and non-verbally, share ideas and interests, and negotiate in a positive way. They may appear deaf. when you're trying to communicate with them, and they often immersed in an activity that interests them. They have an impairment of, or may have an impairment of social imagination, so decreased capacity to think about or predict the consequences of one's own actions for oneself or for others. So children with autism spectrum disorder need specialized education help with as much integration as possible. The spectrum is very broad, but the child needs to be recognized as having special needs. Intelligence can range from impaired to superior and can be very difficult for children who are twice exceptional. So this 2E, or term twice exceptional, is commonly applied to high ability children who have learning difficulties. So it refers to the fact that children are exceptional both because of their intellectual gifts as well as because of their special needs. I think it's also really important at this point to remember that it's not just the individual with special need, with autism spectrum disorder who struggles, it's the family. And we need to be mindful of those struggles, the struggles that parents go through, and the struggles that the parents go through in advocating for their child with special needs. And that'll follow on to the slides later in my presentation. I've noticed that there is, in my time, both as a general dentist and as a specialist in special needs dentistry, I've noticed there is a significant difference between parents of younger children with ASD and those with adult children with ASD. And I don't think it's just about their age that makes the difference. I think it's the length of time they've been managing their children with ASD, but also the evolving changes of society and health professionals, as well as accessibility. Happ and Ronald consider the triad is fractionable because of different genes that are responsible for different elements. So I think it's important to also consider the different etiologies as well, because this is also going to impact on parents and parents' perception and how, and it can obviously interact, it can impact on the dental clinic. So there's obviously the genetic component. A number of investigators suggest that autism spectrum disorder appears to be a genetically influenced multi-systemic model in which environmental factors affect biological processes in the body or modulate gene expression within the nervous system. There have been several investigations dating back to the 1970s that indicate that identical twins have a much higher concordance rate of autism spectrum than fraternal twins. And those studies have provided some of the best evidence that these disorders have a strong genetic component. But but the identity of these genes involved, much less how they produce autism spectrum, has not been established. Moreover, the concordance rate between identical twins is not 100%. So this suggests that at least some of the cases must be associated with environmental or epigenetic factors. There's lots of research into the neuropathobiology of the brain, particularly the limbic system and the frontal nodes, and interconnectivity between particularly different parts of the brain, including the cortices. Some studies have identified parental conditions such as maternal vitamin deficiencies. What is in vogue at the moment as well is in the enteric microbiome that is thought to be responsible for all kinds of things. And of course, ASD has jumped on that bandwagon as well. Other systemic disorders have also been implicated: oxidative stress from the environment, high testosterone levels, and metallic elements such as mercury, particularly used in the preservative of vaccines up until 2001. Over 100 different genetic disorders have been identified as playing a contributing role. So there are multiple studies that look at twins, and obviously these have at least given evidence to the genetic factor in this. So I think that's a reasonable look at the background, but I think we've got to again draw our attention to the individuals and the human aspect of this disorder. So this is an example, and I think we need to remember how that we need to also celebrate these individuals, and again be mindful that this is just a different processor that we're dealing with, different from our neurotypical selves. So this is Stephen Wiltshire. He is a British architect. He, after just a 20-minute flight over New York City, he was able to draw this picture of New Jersey, Manhattan financial districts over the following 5 days. Absolutely incredible. These are figures in popular culture that also have been identified as having autism spectrum disorder. Most of note is Jerry Newport, who is an author and public speaker with Asperger's syndrome, whose life was the basis of the 2005 film Mozart and the Whale. He's known for his frank advice and humour when giving presentations. He's a graduate of the University of Michigan with a BA in mathematics, and he's a savant, and he has the ability to perform incredible mathematical calculations in his head. So diagnosis of course is very important, and in most of all, early diagnosis and treatment of autism spectrum disorder is crucial in order to develop social skills, language and motor skills, and appropriate social behaviour. This is usually a two-step process. So generally there's a developmental screening that happens at the age of 9, 18 and 24 months, which is a short test examining whether a child has learnt and met certain milestones, how a child behaves, speaks, learns and moves and so on. If something has been identified, then a more comprehensive diagnostic evaluation happens. There are many tools that can to assess autism spectrum disorder in young children, but no single tool should be used as a basis of diagnosis. If the GP picks up that there is an issue with any of these domains, then they refer to a pediatrician or child psychologist, psychiatrist, or neurologist. So early signs and symptoms include no big smiles, or other warm, joyful expressions by the age of 6 months or thereafter, no back and forth sharing of sounds and smiles or other facial expressions by the end of 9 months, no babbling by 12, no back and forth gestures such as pointing, showing, reaching or waving by 12 months, no words by 16 months, and no two-word meaningful phrases by 2 years. Any loss of speech or babbling, and any loss of speech or babbling or social skills by any age as well. So another important aspect to consider is that ADHD and ASD are often misdiagnosed and interdiagnosed. So it is true that both disorders are more prevalent in males than females. However, ADHD is very different to autism spectrum disorder. That's not to say that that individuals can't have both disorders. However, it's important to separate the two. So people with ADHD may be impulsive, hyperactive, they have poor mood regulation, whereas people with autism, they're not impulsive, they're not hyperactive, they don't have poor mood regulation. People with ADHD is a disorder of doing. They can't sort out what to attend to first, whereas an individual with autism is able to focus on a task so long as they are interested in it. However, they may have issues with sorting out what to attend to if there are too many stimulations, too many verbal instructions. Problems in both disorders can escalate with increased demands. However, it all depends on overstimulation with autism spectrum disorder. In terms of management, and there's obviously behavioural management of both conditions, and most commonly with ADHD, Ritalin is used. However, the medications used in autism are symptom specific. So I'm just going to quickly run through the general characteristics of autism spectrum disorder. And an important concept to get hold of is this impaired theory of mind. So theory of mind refers to the ability to understand and predict the behavior or emotion of others, okay? Due to a dysfunction in the mirror neurons, people with autism tend to exhibit difficulty in predicting other people's emotions. And you can imagine that would be pretty scary, not knowing, you know, how somebody is going to react to a certain situation or to you, or and really what I want to try and communicate and for me to bring across is what it is like to be somebody with autism spectrum disorder. So there are cognitive impairments, both impairments in self-referential cognition as well as empathy. An individual may have a cognitive impairment, they may have an IQ, a lower IQ, and this is this occurs in approximately 40% of individuals. But I think it's also important to remember that not all, and actually the vast majority of individuals with autism spectrum don't actually have a cognitive impairment. There is also a strong association with epilepsy as well. So people with autism have precise interests. They can appear obsessed. If something doesn't interest them, then forget about it. They love facts, and again, I hope that the passage that I read illustrated that. Sorry, incidentally, I should have said the book that I read from is The Curious Incident of the Dog in the Nighttime. This is a great book, which I think really illustrates autism very well, probably better than my lecture will. Children often with autism spectrum disorder ask, you know, why do children have friends and I don't? So there's a real risk of social isolation, and following that, a risk of depression. Any changes in routines can be incredibly disruptive and may precipitate outbursts in aggression or challenging behavior. And there's this overwhelming need for sameness. There's no shades of grey, it's black or white, it is or it isn't, yes or no. However, for those of us that don't work in binary terms like this, we can use scales to try and build a way of bridging that, the communication between those two processes. So yeah, individuals with ASD, there are special challenges, they have special gifts. You know, I love my job. I feel very privileged to have built relationships and trust with my clients with autism spectrum disorder. Yeah, I think I feel the joy and acceptance from those individuals. So there are multiple therapies. The main therapy for autism spectrum disorder is early psychosocial interventions geared towards social skills, speech and language, and behavioural management. I have mentioned that there are pharmacological interventions, generally for more severe cases. So the use of tranquilizers, antipsychotics, antidepressants, anticonvulsants, benzodiazepines, stimulants, and antihypertensives. I'm going to briefly just run through these because they do impact on us as dentists. So antipsychotics, people with autism may be prescribed risperidone, which is an atypical neuroleptic. And this is the only FDA approved drug for the use in autism. The indications include severe irritability, aggression, and mood disorders. For us as dentists, we need to be mindful the side effects may include tardive dyskinesia, as well as sialorrhea as well. So those can be challenging, as well as the autism spectrum disorder itself. Antidepressants, so SSRIs, selective serotonin reactivity inhibitors, and again, this can help with this, overcome the desire for sameness. We know that with antidepressants, there's often the side effect of xerostomia, and taste changes as well as tardive dyskinesia. You also may need to be mindful that if you're prescribing something like erythromycin as well, this may inhibit metabolism of these drugs. Anticonvulsants, so more and more anticonvulsants are used not only in autism, but also in other mood disorders such as bipolar disorders as a management of mood stabilization, not only obviously epilepsy. So drugs such as carbamazepine, phenytoin, sodium valproate, lamotrigine are used to manage aggression and mood swings, as well as seizure disorders. Hypertensive drugs such as clonidine also help manage impulsiveness, irritability, and hyperactivity. And stimulants, obviously, such as Ritalin, used for ADHD, as well as autism, those that exhibit hyperactivity. Benzodiazepines, obviously used for anxiety and help with insomnia as well as agitation. So the dental issues associated with autism spectrum disorder, I think it's important to remember that between 30 and 50% of children with autism spectrum disorder are capable of receiving dental care using behavioral management techniques alone. So, individuals with autism spectrum disorder have a variety of sensory processing or sensory integrative difficulties. So those two terms are interchangeable. This is a way in which the nervous system processes and responds to information obtained through these senses. The prevalence of these processing difficulties has been reported as high and in as much as 80 to 100% of individuals with autism spectrum disorder. So to sort of try and illustrate sensory defensiveness for those that are neurotypical. So if you want to picture this, just imagine that you've just sat down to a relaxing dinner on a Friday night at your favorite restaurant after a long, demanding week with colleagues and patients, and the couple next to you has a toddler who is shrilly screaming at the top of its voice constantly for the next hour and a half, and nobody is doing anything about it. On top of that, you're having a flaming row with your partner. Now magnify that by 20, and you've got something of the frustration and the pain of somebody with autism, trying to deal with all the different senses encountered in the dental office and the changes to their routine, all of which they have no control of. You know what it's like in work. When you're feeling overwhelmed, you get snappy, or at least I do. Bergman and Scolia in 1949 first described sensory-based hypothesis of autism, whereby they believe children were overly sensitive and therefore developed defenses to the social world. Rimland in 1960 developed an under-arousal hypothesis suggesting that the reticular activation system was functioning improperly and was impairing the ability of a child with autism to learn through pairing current and past experiences via sensation. So one specific type of sensory processing difficulty, is sensory defensiveness, which is a behavioral overreaction to extreme avoidance or common sensory experience that others who are neurotypical would find normally tolerable. So touch aversion, certain types of sound, sense of movement, so sight, as well as position of body parts, taste, smell. So all of the different senses that we have. Auditory input may block the perception of other inputs. So some individuals describe this as channels getting crossed. And this sensory defensiveness is an area that occupational therapists can help us with. So an individual may be able to tolerate one type of stimulus, but then become more and more agitated if multiple stimuli are added. Sensory processing difficulties will lead to a fight or flight behaviours, and fear or avoidance may escalate to physical aggression if the fear or discomfort is not respected or attended to. So you need to be in tune with your client's needs. You need to see, and if you're ignoring them and you're not paying heed to the warning signs, then things will escalate and can escalate quite quickly. So this lack of cooperation has been documented in lots of different studies and has been reported as high as 65%, and some other studies have said it's 55%. Children commonly display sensitivity in and around the mouth, and of course that is obviously bad news for us. I think it's also important to acknowledge that it isn't just sensory defensiveness that can be an issue. It's also, so sensory sensitivities alone are not responsible for all behavioural difficulties, so it's not a catch-all in any terms. Other factors include communication difficulties, IQ, dental fear and anxiety, and these have all been found to predict uncooperative behaviour. So sensitivity of fears. So in general, even when we're talking about neurotypical individuals, try to avoid discussing anything related to fear until the child is old enough to be able to realise that it isn't going to hurt them, so that they're able to rationalise and understand a way around fear. Try to stop carers and parents and siblings from blundering in and doing the same, okay? Another important thing as well, so not only this, not only sensory defensiveness, but in addition to sensory processing disorders, individuals with autism spectrum disorder may also have altered sensory perception as well, known as synesthesia. So synesthesia is a condition where senses are overlapped. So you may be able to taste a colour, or numbers may have some auditory meaning to you. And this has been thought to contribute to the individuals with autism spectrum disorder exhibiting extreme memory skills. So what are the triggers? I think the first thing when you are trying to work out what may trigger these outbursts and intolerance to the dental setting is ask the caregivers first. They're likely to be the to know what to advise you there. So if we split it into sensory domains, reaction to visual stimuli, so difficulty tolerating bright light. There's also a fear of dental staff when their faces are covered. Remember, people with autism spectrum disorder have difficulties making eye contact. So instead of making eye contact when they're communicating with somebody, they often look to the mouth. If you then cover that up with a mask, then you're breaking down you're creating a barrier in communication there. So reaction to touch, and really, really importantly, particularly light touch, and overreaction to unanticipated touch as well. So, you know, putting your hand on the patient's shoulder, or suddenly putting your fingers near their mouth, and so on. An oversensitivity to dental prophylaxis, so the sensation of the cup or the brush or the grittiness of the paste, and an unusual response to dental tools, so radiographs. I don't think that's unusual. I think radiographs are bloody painful. Cotton wool rolls, gloves, and an increased gag reflex. So a disruption to routines, I can't emphasize that enough as a trigger for outbursts. Reaction to motion, people with autism may exhibit extreme fear as a response when the dental chair starts to recline. Reaction to sounds, so polishing brush, obviously, you know, things that would trigger normal dental anxiety or dental phobia, but also other noises that may occur, such as alarms or intercoms or announcements or beeps. And another thing to be mindful of as well is an adverse response to people talking or laughing in a dental clinic. Unfortunately, the clinic that I work in Darwin is very echoey, so I'm extremely mindful of when cupboards or drawers are open and closed, as well as any noise created by any other individuals within the dental clinic itself. Reactions to smells and tastes, so the taste of the glove, the taste of the prophy, the toothpaste, you know, there's lots of different tastes that are happening. Topical anesthetic varnish, perfumes or soaps or detergents in the dental office or staff. So modifications, so those are the triggers. Now, how can we overcome those triggers? I think it's important, and the literature says there is no set program that works best for all patients. And I think the first thing that I tell my undergraduates is that everybody sits down and everybody shuts up. Okay, and that includes parents, carers, dental assistants. What you want is one voice. You don't want any chatter. You don't want any competing instructions, and you don't want any other distractions. You do not want to be dividing the attention of the client. The language. Use of literal words. So again, from the discussion from that book about metaphors, use literal words in a calm voice, no jargon, no sarcasm, no metaphors. And parents and carers can help interpret behaviour and language. Behaviour and communication. So movement, you can have the chair fully reclined before the patient gets in, or you can let the patient control the reclining mechanism themselves. And that can actually be quite a fun, engaging task. So in terms of auditory, there's no issues with sticking headphones on during the dental appointment, provided that you do obviously maintain communication with the patient. You may want to provide white noise, and again, minimize outside sounds. So pop them in a clinic that is far away from any other disruptive noises if you possibly can. And also make your support staff well aware of the client that you're going to be and the expectations that you require while you're managing a client with autism. So verbal preparation. So, and I think this is the other thing, is that to be mindful that people with autism spectrum disorder are not deliberately being obstructive, okay? They are trying often as much as you are to get the outcome, the best outcome. So yeah, don't think that it's just a one-way street. Some people with sensory defensiveness will better handle the sensory stimuli if it is expected and predicted. Okay, so that goes for all sensory stimuli, from touch to sound to taste and so on. So discuss the clinical visits ahead of time. Give a set amount of time that the input will occur. If they are forewarned and prepared, they're far more likely to endure what you're going to do to them. Provide a timetable or a visual indication of when you will be done, and count. Counting, I think, is one of the most important tips and tricks for managing young children as well as clients with autism spectrum disorder. So count 1, 2, 3, 4, 5 and stop, and repeat 1, 2, 3, 4, 5 and stop. The patient knows exactly how long they have to tolerate an intervention, and often they will allow numerous repeats over that time, just as long as they have, they know exactly how long they had to endure it. Taste and smell. You may need to alter your gloves. You may need to have a variety of pastes and gloves. Our staff members not to wear perfume. You know, it's not a night out. You don't need to be heavily perfumed, and that includes deodorants as well. And soaps. There are plenty of deodorant soaps out there that don't have any smell. And that also goes for the soaps that you use in the clinic, and avoid air fresheners as well. So other modifications to the environment: visual, choose dark glasses rather than those clear protective glasses. Care when positioning the light to make sure the light is away from their face when you turn it on, and then make sure it's just positioned over their mouth. Dim overhead lights if you possibly can. Avoid direct eye contact. Again, that is obviously a case-by-case thing. Some people with autism do make eye contact. Face shields rather than masks. Obviously, this is not an ideal time to start implementing that. With COVID, touch. Use as little touch to the patient's face as possible. But when you do use touch to the patient's face, make sure that that touch is firm and deep touch rather than light touch. Alter the texture, grit of the paste, allow more frequent rinsing of paste. And I know that we've done away with spittoons in many of our clinics, but you may need to accommodate that as well. I always make sure that I do have facility for my patients to spit out as regularly as they like. So other modifications, so using deep touch or pressure and or heavy work before or during a distressing sensory events can help with sensory defensiveness. So pressure, massage, elasticized wraps, weighted clothing, vibration, tight clothing, tight hats, or even just lying something heavy on the patient like a weighted blanket or an x-ray apron. Again, collaborating with patients or carers. There may be strategies that they have already implemented with other medical procedures, such as deep oral pressure or vibration of an electric toothbrush, a mini massager, or rubbing with an oral swab prior to the appointment. A word of warning though, with oral swabs, they can be bitten off, swallowed and choked on, and they're never a good idea to recommend as an oral hygiene aid. Okay, they don't do the job and they just pose a risk. Use of, again, a heavy or tight hat before or during the appointment. And also other things such as a fidget cube, a squeeze ball, a stretch toy, or something that provides heavy work. When I think of fear, and the fearful situations that I am in quite regularly, I think of when I'm flying, which for me is terrifying. And I often have to travel across the top end of Australia during the wet season and experience lots and lots of turbulence. When that happens, I experience a fight or flight response and the absolute helplessness of being at the mercy of another individual's competence. I grip the armrests or the seat back in front of me, and I push my arms against the armrests or clench my fists. All the time, I'm exerting pressure in an attempt to mitigate the unpleasant sensation of fear. The pressure can help those with ASD for exactly the same reasons. So prior to the dental appointment, I think it's really important that you get all your ducks in a row before the individual with ASD arrives. So get the medical summary beforehand, get the list of medications, contact the GP or carer. Don't waste time and keep the patient waiting during the appointment doing these tasks. Ask the carer the level of tolerance. It's a good idea to get a pre-visit questionnaire. And look at their oral habits, their physical function, communication, vision, hearing, behaviour, sensory sensitivities, emotions, as well as a thorough record of the patient's limitations and any reactions to previous medical or dental treatment. Discuss management strategies and education methodologies with the carer and adapt these to your dental approach accordingly. So what incentives work is food use as an incentive, recreational activities, or are there any other unconventional reinforcers such as movies or video games? Do remember, and again, I'm repeating myself, but it's important that patients have with ASD have a range of intellectual functioning, and you may have to consider whether or not they have capacity to consent, and that's a whole other lecture. Just remember that an individual may have capacity for a certain procedure, such as an examination or a scale and clean. However, they may not have the intellectual functioning and capacity to say consent for the risks associated with a general anaesthetic. Do they have an alternative decision maker? And if they do, you need to find that out before you start seeing them. So these are two questionnaires that are from this paper by Travis. and these could be quite useful for you. One is the pre-visit questionnaire that goes through all of those things that I've just talked about, and the other is the dental visit preparation guide. So you can actually record, and individualize your approach to an individual with autism spectrum disorders, remembering that it has to be an individual approach because obviously the spectrum covers a variety of individuals. So at the appointment, how can we improve the dental visits for those with ASD? And I think the first and foremost, we need to let go of traditional norms and strategies and expectations for dental patients. Prepared to be ridiculous, okay? That's what, that's part of the course for me. Never ever keep patients with ASD waiting. Avoid waiting times, and to that end, it's probably better that you book them in first thing in the morning, so that you're not, there's far less chance of you running late. Keep appointments short, so 15 to 20 minutes maximum, but keep the appointments regular. Remember, you're trying to build a routine up here. If you can build a routine and an expectation, then that's half the battle won here. Children with ASD learning short bursts and are more likely to retain this learning when it is delivered in small increments. More than half of the patients with autism do not have an intellectual disability, so be mindful of that. And I think it's really important that you are just be constantly aware of that sensory over-responsiveness, okay? And be aware that, of any behaviours that may indicate things are escalating, because it's the ignoring those signs of escalations that's going to get you into trouble. Be consistent. You're trying to establish routines, so same clinic, same dentist, same DA, same expectations. Keep the instructions brief and simple, so the use of picture exchange communication, dental pictures, written rather than verbal. Remember, individuals with autism spectrum disorder are visual learners, and you may want to consult with a speech and language therapist or pathologist. Individuals with autism have a range of pain thresholds. Some may be very sensitive to, again, I'm repeating myself here, to brush against the cheeks, while others may not present any response to pain at all. And I'm always amazed when individuals flinch from, say, me examining their face and then being completely fine with me giving them a block. The tell, show, do can help as well. So step-by-step visual clues where the patient brushes teeth, social stories, photo books. These are all helpful aids. Desensitization appointments. So systemic desensitization has very high success rates. However, the lasting impact and generalizability of the success can be questioned. A patient may be capable of learning to receive an examination, but the skill might be limited to a specific treatment environment and with a particular provider. So just because somebody has had, when you're taking a history, somebody's been able to have examinations and simple dentistry before in the past, that may be specific to the provider that's provided it and not necessarily reproducible with you. So that's important to remember. Impairments in foundation social skills, such as reduced social motivation, impairments in social reciprocity, or deficits in joint attention may impede success of the gradual process of exposure approach or lengthen the time to success. It's important to determine appropriate candidates for desensitization. So ask the carers, ask the parents, ask the other health professionals involved, the other stakeholders about the social impairments to identify social and emotional engagement with other previous strategies. Alternative approaches to those with extreme aversion to social interactions or those with active dental disease may be required. So I think another important thing is, often patients are referred to me with the expectation that they're going to go straight to GA. Remember, hospital admissions for procedures should be kept an absolute minimum because this is a marked change in routine. And this can be very upsetting. So just because somebody can't be handled in a dental setting or may not be able to be handled in a dental setting, don't think that it's a picnic when they're going into a GA either. And you're just transferring one set of problems in one area to obviously those that are trying to handle them in an anaesthetic setting. So one voice at a time. Video feedback, we were in the age of the smartphone, so self-modeling and pro-social behaviours can be videoed on phones or tablets, and we can use those photos and videos to encourage carers. So encourage carers to take videos and photos while you're treating and managing the client. Peers and siblings can also be used as role models. So before a child with autism gets into the dental chair, that might be a good idea to tack it on to an appointment with a sibling or a parent, so long as you're not doing anything horrible like taking teeth out or giving local anaesthetic. Sensory adapted dental environments, so facilitate cooperation, so remove stressful stimuli, declutter your office and conceal instruments. Other important tools may be repetitive visual color effects such as solar projectors or rhythmic music. Clarify expectations, okay, before you embark on anything. And the environment, quiet rooms for consultations. You don't have to carry out the examination in the chair. In my clinic in Darwin, I've got a nice big comfy couch, and more often than not, that's where I'll be conducting my examination with a head-mounted light, obviously being mindful of not shining it in their eyes. So quite often my clients are very receptive to having their teeth counted on that couch, but won't venture into the dental chair. Sometimes I've had clients, young children being swung upside down by their parents while I try and have a look in their mouth. I've sat on the floor of a kitchen before now, trying to, in order to examine a client. You have to, once again, you have to, remember what I said, let go of traditional norms and strategies and expectation for dental patients. So the oral issues, epilepsy, in approximately a quarter of individuals with autism spectrum disorders. So you've got the oral effects of medications such as gingival hyperplasia, and also delayed eruption in those, obviously in children that are using anticonvulsants. Seizures, so seizures can precipitate trauma, and if you are taking an individual to a GA, always take a PA of those upper teeth, because quite often trauma goes unseen and unreported, and then years down the line we realize that those front teeth are actually non-vital. Trauma, head banging falls, accidents are quite common. Tongue thrusts, oral habits such as self-injurious behaviours, cheek and lip biting, as well as pica, so using obviously non-nutritional things to stick in mouths. So bruxism, more and more we're using Botox. Obviously individuals with learning disabilities are going to be less amenable to putting splints in and things like that. So Botox may be a viable alternative here. It's been noted in approximately between 20 and 25% of those with ASD, as well as gastroesophageal reflux disease. Dental caries, so Silver et al. In 2014 did this comprehensive systematic review and meta-analysis of the oral health status of children and young adults with ASD, and found that the prevalence of dental caries and periodontal disease was high amongst these individuals. There are numerous studies that look at the oral health of patients with ASD, and some say caries is higher in the general population, some say it's lower, and so on. But this top level evidence says that it is high. They may have an oversensitive gag reflex, and as well, many are reported with multiple allergies as well. This is another interesting paper that from the journal, the American Journal, Dental Journal, that talked about different autism spectrum disorders and different concerns with dental materials and medications and medicaments. And I think forewarned is forearmed, because, as I said before, parents with children with autism lead very challenging lives. They are they're obviously they are used to being advocates. They're used to doing their research. So sometimes we need to be able to have frank discussions around their fears around all sorts of different things that they believe may be contributing to their child's condition. So mercury, although dental amalgam is considered to be a safe and effective restorative material, obviously going out of fashion now, alternative medical literature suggests that children with ASD are genetically predisposed to an inability to clear the body from heavy metal contaminants. And this has led to children, there's no high level evidence around this, but despite this, some children undergo biomedical chelation therapies to remove these metals from their bodies. Adams et al. In 2017 showed, and this was an repeated study, showed that apologies to the lights going out, showed that an excess of mercury in the dental pulps of primary teeth in children with autism. The authors inferred that children with autism spectrum disorder have an inability to clear the metal. Fluoride, and just to enter into the great fluoride debate, suggestions have been made again from alternative medical literature that fluoride inhibits critical antioxidant enzymes and has been linked to excitotoxic reactions within the brain. Patients may wish to minimize exposure to fluoride as an important part of biomedical treatment. There are also concerns with children who eat toothpaste and that are unable to spit out the toothpaste after brushing. We do know that fluoride is a GI irritant, and that prolonged exposure can damage the gastroduodenal mucosa, and children with ASD often are reported to have significant GI issues. And staying on the subject of GI issues, gluten, casein, and other dental materials, several studies have suggested that GI problems are common comorbidities, including discomfort, diarrhea, and gastroesophageal reflux. Autism is frequently treated with applied behavioural and occupational therapy. However, when GI problems are treated, many parents have stated that their children's behaviour also improves. So obviously, parents of children with those with autism who have identified GI disturbances, they're going to be very wary of any materials that are likely to upset their child's GI tract, if it might precipitate challenging behaviour. There's also, again, alternative medical literature around nitrous oxide as well. And of course, if you do have a child that whose parents are wary of nitrous oxide, then it might be a good idea to use an alternative sedation. Again, staying on the theme of GI disturbances, antibiotic agents, and we should be using antibiotics, particularly in this day and age, judiciously anyway, but there is, of course, the relationship between antibiotics and upsetting the intestinal microbiome, which may exacerbate GI disturbances. So the use of probiotics may be advantageous, and dentists may also wish to consult with the patient's GP before prescribing antibiotics. And lastly, as well, paracetamol has even been suggested by Schultz et al. In 2008, which is an unsubstantiated study, but the results have suggested that paracetamol, used after the MMR vaccine in children, has been associated with ASD. So it is important to be mindful of all these different theories, because sometimes the parents of individuals with ASD do hang on to these. So a staged introduction of the dental setting is recommended. Close coordination with the carer in regard to the patient's behavioural management therapy, particularly with regards to rewards. Obviously, if an individual has an inability to keep still or keep the mouth open for a length of time, then you're going to be using GIC restorations over composites. And also this multidisciplinary approach is probably advantageous. So, contacting the patient's GP, liaising with their occupational therapist or speech pathologist. So sedation, which is often people think is the go-to for people with ASD, sedation, GA, protective stabilization, these are euphemisms, and clinical holding are all commonly used in this population to greater or lesser degrees. And whilst they do address the immediate dental needs, they are associated with increased physical and psychological risk, and they do not promote long-term compliance or the ability to assess oral healthcare. So whilst it might be difficult just to use behavioural techniques, if you skip those and go straight to these sedation GA, then you're actually enabling that individual to gain any skills to receive oral health care. So nearly there. Home care, and most important and often more important than actual clinical care. Motor function is varied, or hygiene maintenance issues with those with poor coordination or intellectual ability. Food is often used as a reward, so make sure that you are counselling carers with the use of fermentable carbohydrates. That said, these might be, the use of Coke or, I don't know, iced coffee or whatever. That might be the only reward that a carer has. Don't go depriving them completely of their ability to manage their challenging client or child. You just need to work with them, okay? Think about alternative preventative strategies, such as the use of tooth mousse, high fluoride toothpaste, and so on. Don't just stop, don't throw the baby out with the bathwater. Stein et al. In 2011 reported that 40 to 50% of children, the parents of children with ASD, reported difficulties with oral care on a daily basis, including aversion to the taste of oral toothpaste and dislike of the feeling of toothbrush. Strategies that have proved successful. Approximately 50% of parents believe sensory processing difficulties interfere with the child's oral care. So in order to overcome that, strategies such as, a staged oral hygiene, starting with oral massage, followed by the use of a washcloth on the teeth, and then followed by the use of a toothpaste. Remembering the other strategies that we've already discussed, such as, use of weighted blankets or restrictive clothing, those sort of things that allow pressure, the use of music, distraction, repetitive music, and so on. Experimenting with different toothpaste, even if you're not using high fluoride toothpaste or so on, even the strangely flavored such as strawberry toothpaste, if you're getting some fluoride in there, that's better than nothing. And there we have it. I'm sorry to have run so late. Here are the references that I haven't covered in the presentation. And I think we've got some time, or we may have time for a question or two.
Thank you, Professor Lee, for a very comprehensive overview of autism spectrum disorder, including its history, signs and diagnosis, and how you can modify the dental setting to appropriately manage patients who have autism spectrum disorder. We do have a couple of questions, quite a few actually, but we may not have enough time for them. So we appreciate that everyone is very busy and that it is now 8:14 or 8:15. So if you do need to go, you are able to close the Zoom window and it'll take you automatically to the survey. So please feel free to either stick around, or if you do need to go, you're welcome to complete the survey now. So we will try to answer a few questions before we close for the evening. And I think there's a few similar questions. I think one that has come up is if a patient presents showing signs of autism spectrum disorder, but their parents haven't disclosed that their child has been diagnosed with autism spectrum disorder, how would you broach the subject with the parents? And would you recommend that the parents investigate this with their doctors? Or how would you approach that?
Yeah, that's quite a difficult question. I think that trying to question parents around other medical interaction is probably a good start. Discussing with them, previous experiences, how they cope with that. And I think that's probably a good way to start the conversation and draw their attention to potential issues there. I mean, I guess we've got to remember that we are dentists, we're not GPs, so it is difficult. I'm not qualified to make the diagnosis, and sometimes you might be looking at a child with ADHD rather than ASD, or a child with other challenging behavior. So I think if there are some sort of red flags there, then you might want to, you just got to be very careful about labeling children with, it's so easy to get parents offside with any kind of aspersions about their child being anything other than normal. So I think that the most important advice would be to tread very carefully and to try and instigate some insight into with the parents by exploring challenges in the rest of their lives, how they interact with other individuals. Remember, when we're taking a social history, we're often talking about those very interactions that may demonstrate some kind of behavioral difficulty. So I think the advice is cautiously.
Thank you very much. I think definitely a difficult area to navigate, and being cautious would be very helpful. We have a couple of questions as to managing patients, and I guess in terms of demonstrating what the procedure may involve. Would you recommend using a model of the mouth to demonstrate and inform the patient about what you will do? As in, would you use a tell, show, do technique with patients?
So absolutely, I think that's one, because clients with autism spectrum disorder are visual learners. The other thing that you can do, which is very useful, and we really do need to take advantage of the technologies that are readily available these days, but there's lots of videos and online YouTube videos that are useful for parents to prepare children to go through, and as I said before, this modeling behavior can be really useful, both using actors, so going on YouTube, but also using a sibling or a parent to demonstrate appropriate behavior and prior to them, to the client themselves jumping in the chair. I think this is all really, really important. It's no good, discussing things early is one thing, but having some sort of pictorial demonstration, and engaging with the other stakeholders. A lot of the, the nuts and bolts of the dentistry, as we know, that's the easy stuff. The carpentry is the easy stuff. It's that making sure that you're prepared and the client is prepared before, which is the tricky stuff, but also the stuff that's going to facilitate you being effective.
Thank you very much. There's quite a few more questions, but I think due to the time, I might just share some of the comments that have also been submitted. So we have other clinicians mentioning that they've carried out examinations in varying environments, such as hanging over the side of a swimming pool, school playground, equipment, backseat of parents' cars, or even a chicken coop. And so I guess just, again, adapting to the needs of the patient is required in some circumstances. And another person has said that examination in the waiting room can work well lying in a bed and even in the bath. And so, again, working within the environment of the patient and what they're comfortable with. And lots of thank yous for a great presentation.
I'm sorry it was so quick, and I'm sorry it was so dull, but I just wanted to get through. It's obviously a massive area, and I wanted to give you as much as possible in the time.
It was a great presentation, and I think it's very comprehensive. And so I think lots of very valuable tips on what you can do to modify the treatment experience or the clinical experience for patients. And so I think, yeah, lots of wonderful presentations and thank yous. So thank you very much, Prof. Lee, and thank you very much, everyone, for your attention.